Dear participants of the Third Orphan Forum, focused at the development of a medical care system for patients with rare diseases. We are very happy to see you all here at our session, which is titled International Experience of Development of Genetic Technologies in the Medical Care System for Patients with Rare Diseases. First of all, I would like to thank the organizers of our forum for their efforts to collect us all together, for this opportunity to have this venue to share international experience in genetic technology development in different medical care systems for orphan patients. Our session has combined 8 speakers from 8 countries at this site, and everyone is going to present our own experience, our system for diagnostics of orphan diseases, our challenges, and our opinion as to how we can resolve these challenges. For each country, studying international experience is of special importance, as well as collaboration in genetic technologies, and indeed each of us is very different. We have different mentalities, different infrastructural realities, different accessibility of medical diagnostic tests, and different medical care systems. But we have something in common. It is our commitment and desire to help our patients and to make genetic technologies readily accessible for them. And we understand very well that these differences between us is not something that will divide us, but rather will be the main reason for us to join our efforts. And the key targets of our session will be exchange of international experience in genetic technology development. The centerpiece will be state-of-the-art approaches to medical diagnostics, development of laboratory and expert infrastructure, organization of screenings, and most importantly, capabilities and prospects for international collaboration for a better access and quality for rare disease patients. We wish our session to be fruitful and successful. And now let me start. Let's get down to business, and I'm happy to introduce you to my co-moderator, Professor Ayman El-Hattab, Director of the Center for Genetics and Rare Diseases, Abu Dhabi, United Arab Emirates, also consultant for clinical geneticist, Professor of the Department of Medical Sciences of Khalifa University, the founder and president of a very important organization in MENA region, the Rare Disease MENA organization that joins Middle East and North Africa countries. And let me introduce myself. I'm Gulnara Svyatova, Doctor of Medical Science, Professor from the Center of Molecular Medicine, President of the Medical Geneticist Association of Kazakhstan. Taking into account a very dense agenda, very busy agenda, I would like to excuse myself in advance, but I will strongly insist that every speaker fits into the 10-minute timing. Questions could be asked either verbally or written to the chat. And now the floor for the first, the honorary right to open up, inaugurate our session is given to Professor Ayman El-Hattab, whom I have just introduced. And it's going to be a very interesting and informative presentation titled Genetic Diagnostics and Population Screening in the Era of National Genomic Programs in the Gulf countries. The floor is yours, distinguished professor.
Thank you very much, Prof. Gulnara, for the kind introduction, and I'm very thankful for the organizers for the kind invitation. It's really an honor to be here and to present about genetic testing and genome programs in the Gulf countries. Again, I'll try to stick to the time. So you see my slides, right? Okay. We will be discussing the genome programs in Gulf states and how these are connected with genetic diagnosis and screening. And I'll be focusing more on United Arab Emirates, where we have really a unique system for genome programs and genetic testing and screening. And also we will talk about the other Gulf countries. So in this map, we see the 7 states in the Gulf countries, and we will start with United Arab Emirates. And the first is to talk about the Emirati Genome program that was started in 2019. And this program aimed to first build a national Emirati genome database, as most of international databases are based on European and North American populations, and the representation for Middle Eastern population is really little. Second goal was to understand the prevalence of variable genetic disorders in this region, and understand if we have like a specific pathogenic variants linked to these conditions. Then to enable personalized and precision medicine to help in providing better care for our patients. And as we will discuss after a few slides, this program helped in prevention through screening programs, and also is trying to determine the risk for chronic illnesses and cancer. And of course, these programs aim to advance research and technology in genetics through applying the most advanced methodologies and systems. So what have been achieved since 2019 is amazing. The goal was to sequence 1 million cases, and now we crossed 800 samples being sequenced. More than 5 million novel variants have been identified, and then we now have like one of the largest Middle Eastern genomic database, and understand the incidence of variable population-specific conditions. They have applied the most advanced technology and AI for data interpretation and management. Now, this is like a project, a research project, let's call it. But now the unique part is how this program was integrated in the healthcare. This was done through first establishing a clinical lab, Biogenics. So this lab was established to provide clinical reports for patients. And then this lab provides whole genome sequencing, gene panels, single gene disorders, all kind of genetic testing. But the unique thing about this lab, now if you think about like the Emirati Genome Project as a research project where you have participants, and these participants are sequenced, and we get their sequence data in the genome database. And then we have the Biogenics as a clinical lab where we have patients and we need clinical reports. So these are not really separated, these are integrated. So if we have a patient that we need a report for, then and this patient has already participated in the EGP, in the genome program, then we can get reports, we get data from the genome program, and Biogenics will issue clinical report. And if the patient is not participated, then we will receive the sample by Biogenics, and we will include this person in the genome project. So both systems support each other, and this actually saved efforts, time, and cost. Now the second point in the integration is the screening program. So through the data that was obtained from the Emirati Genome Programs, we are able to find out the common conditions in the country, and these data were the basis for the premarital genetic screening, where people who are planning to marry undergo a genetic test, includes 570 genes covering more than 800 inherited conditions, related to neurogenetic diseases or metabolic conditions or neuromuscular disorders. These are either like recessive conditions or X-linked conditions that may affect children. And now this program is mandatory for all Emirati individuals who are planning to marry starting from 2005. And the goals, of course, are to first reduce the incidence of genetic diseases, and also apply the preventive measures. So we can apply IVF and testing embryos to select unaffected embryos. And this is very relevant in this region because of high consanguinity and high incidence of recessive conditions. And I'm very glad that Prof. Ambreen is here. She will tell us about their experience dealing with recessive disorders in Pakistan. In addition, samples that are included, that are screened for the premarital screening, will be also included in the Emirati Genome Project. So this means that we will add more data to the genome database that we already have. Now, the second program is currently not mandatory, but soon will be mandatory, is the newborn genetic screening. Now, we have the conventional newborn screening, HELIBRIC, and taking dry blood sample for certain metabolic and endocrine disorders. But now the newborn genetic screening include more than 700 genes for more than 800 conditions that early diagnosis can make difference in the outcome, including metabolic disorders, immunodeficiencies, neuromuscular, and others. And the goals are really early detection. So if we find the condition early, then this will enable early treatment and a better outcome. Same thing, these data also will be fed to the Emirati genome, and will have like more data. I think this program should be is expected to be mandatory for all Emirati newborns in the near future. So in summary, now this model is really unique. We have the Emirati Genome Program that we are able to build an Emirati genetic database and to understand the common genetic conditions, but at the same time we applied these methods for screening that will help in prevention, and at the same time we have like the biogenics, the clinical lab that is integrated with the Emirati genome to provide clinical reports. And we didn't talk much about like personalized medicine, but also this lab provides pharmacogenomics, which is like one of the elements that help in supporting personalized and precision medicine. So in the coming 2 minutes or 1 minute, we'll just quickly talk about the other Gulf countries. In Saudi Arabia, yes, there is Saudi Genome Program, started in 2018 with almost the same goals to establish a database and early diagnosis and prevention. This program aims to sequence 100,000 Saudi genomes. For Qatar, also they have the Qatar Genome program, also started in 2015 with the goal of sequencing 350,000 genomes. And again, this program is very successful. They do clinical genomic testing in Sidra Medicine Healthcare. In Bahrain, they also have their own genome program with the same goals to sequence about 50,000. Kuwait and Oman, still they don't have really genome program, but in Oman they established the National Genome and Human Database Center, and they are planning to start to get more involved in and do more for genomics and testing. Sorry, oops. Sorry, I just want to the last. Sorry. So in conclusion. Yes, it's the genome projects in Gulf Arab states They help in establishing genetic databases to determine the prevalence of genetic diseases. This actually will enhance genetic research, precision medicine, and screening programs. Now, clinical genetic testing is needed for early diagnosis, so it will be great if we can integrate these programs with clinical labs to provide genetic testing. And at the same time, screening is the way to help in reducing the burden of genetic disorders. The Emirati experience is unique in, as it's really integrated this program in with the clinical care and help in establishing screening programs. So finally, I really would like to thank you all, and this is our the conference, the 5th MENA Congress for Rare Diseases, that will take place in Abu Dhabi in United Arab Emirates in September, and you are all welcome to attend. And thank you very much.
Thank you very much, Professor Ayman. This has been a very interesting and informative report, and you told us very well about the specific features of the Gulf countries and MENA countries in general. You also highlighted the high level of consanguinity, which is a specific feature, and another feature, maybe ranking number one, is your tremendous financial resources and your experience in nationwide screening. And I have a question. So, taking into account the high level of consanguinity, which of the types of screening you believe should be the most effective in terms of reduction autosomal recessive diseases, prenatal or neonatal or premarital? What do you mean will be the most important screening?
Yeah, I think yes, premarital, and this system has been applied in these countries beginning of 2025. So far, like 1.5 years, and we start noticing the differences. Some people even may not marry; they stop the marriage, and other people they marry, but they go for IVF to select unaffected embryos. So I think yes, premarital is expected to reduce significantly the burden of recessive disorders.
Thank you. Thank you very much. Are there any questions from the audience? And then I will permit myself to ask a second question. I will use my role of co-moderator. So, do you see a potential for international collaboration with us, with the countries of CIS, Commonwealth, and where we could be useful for you?
Yeah, absolutely. So now collaborations can be done at several levels. So the first one is the technology, the sequencing technology, and utility of AI and the methods of sequencing and interpreting data. The second part is related to data sharing, because I mean this will be very helpful. I mean, if we have our own database and you have your database, so if we share the data, then we know more about the significance of variable genetic conditions. So this is just regarding to diagnosis, but of course, as like we discussed yesterday, the floor is or the doors are really widely open for more collaborations regarding clinical research, and particular like these related to gene therapy and other treatment for rare diseases, where we can collaborate to do the research, find a new treatment, and even manufacture these treatments at much lower cost than what we currently pay for this treatment, which can make therapies for rare and genetic disorders much affordable.
Thank you very much for this optimistic reply. Thank you very much indeed, Professor Ayman.
Okay. So if you allow me now, I'll like introduce you. So because you'll be the second speaker, right, Prof. Gulnara. So I mean, again, it's really my honor to reintroduce Prof. Gulnara, who's a professor and at the Center for Molecular Medicine, and also the president of the Association of Medical Genetics at Republic of Kazakhstan. And Prof. Gulnara will tell us like really an interesting presentation and very important about the genetic diagnosis of orphan disease in Kazakhstan. So we can really see the organization, accessibility challenges, and prospects. So Prof. Gulnara, again, the mic is back to you.
Thank you very much for this introduction. First, I will give you a brief review of our country. We have a large territory, which ranks 9th worldwide in terms of square kilometers, with a relatively low population level, only 20.5 million people, ranking 62nd globally. And as for density, it is 8 people per square kilometer. The density of population ranks us 186th. Here you can see our main indicators: birth rate as of 2025, about more than 300,000 children, 335,000 newborns. In other years, it could be higher, up to 400,000 per year. Natural increase of the population is 11.6 per 1,000 of population, which means expanded reproduction rate. And this vast territory with low population density means that concentration of genomic diagnostics is in the capital and in other big cities of the Republic. Lack of genomic diagnosis methods in the tariff rate of medical services, of course, it creates a great inequality in access to these technologies. And our government pays a lot of attention to these challenges. In fact, financing of orphan diseases in recent 10 years has increased by a factor of 23, amounting 175 billion tenge. And we opened 15 centers starting from 2019, 15 rehabilitation centers, 19 centers for early intervention, and 20 centers for fetus preservation. But the number of children with orphan diseases, including pediatric disability rates, they have gone up by a factor of almost 2. For the first time in many years, the structure of causes of pediatric disability includes inborn chromosomal disorders, ranking first now. This slide gives you our regulatory basis, medical care to orphan patients. First of all, our code that designates criteria for orphan diseases, decrees of the Ministry of Health, according to which the list of orphan diseases includes 62 diseases at this moment, and we purchased 202 drugs to treat these diseases. And the diseases were included on the list of disorders of social significance, so these people have a right for free of charge medical care. And also we need to mention that both clinical guidelines and regulatory documents focus on genome diagnostics of orphan diseases. Methods like ACGH or full genome, full exome sequencing, they are not present there, these methods. The pathways for patients with orphan diseases, maybe I will skip that because it is quite standard. Primary medical aid, primary care, where these orphan diseases awareness is quite high, so they are first of all detected, then referred to the regional level, where they interact with the regional coordinator and specific medical disciplines, and then the Republican level, the purpose of which is to verify the diagnosis. Specificity of Kazakhstan is that our Republic level centers for orphan patients are not unified multidisciplinary centers, but they are separated depending on the nosology. For example, we have National Cancer Center, Neurosurgery Center for adult patients. We have Research Institute for Cardiology and Internal Diseases. And a coordinating agent between all these centers, the Republican Center of Orphan Diseases, starting from this year, 2026, it was the Research Center for Pediatrics and Pediatric Surgery Center. They are the coordinating agent here. And also, in none of these republic level clinics, a basis exists for genetic tests. We don't have this basis. We have this base for in the National Center for Biotechnology, but it only focuses on research and therefore cannot be accessible for practical healthcare needs for our orphan patients. So what are the genetic tests that are covered by the guaranteed scope of medical care? First, it is all the methods of prenatal and neonatal screening, including invasive prenatal procedures, karyotyping, prenatal karyotyping, and unfortunately, newborn screening is done only for two nosologies, phenylketonuria and inherent hypothyreosis. But molecular genetic tests are presented only by FISH method, molecular cytogenetics and FISH method. As part of providing medical care to orphan patients according to the mandatory medical social insurance coverage, this is section number 9, titled Molecular Biology and Molecular Genetics, that covers tandem mass spectrometry methods for diagnostics of orphan diseases, PCR diagnosis, also cytogenetic methods, and modern molecular genetic methods that are focused at only on some limited list of nosologies or at identification of mutations in specific genes, like, for example, Leibniz mutation, prothrombin gene mutation, AZF factor, or HLA typing. So, what are the today's challenges for introduction of genome diagnosis methods in our country? We split them into different categories. Medical challenges. First of all, limited newborn screening, only for two diseases, which results in late diagnosis, inefficient and costly treatment of high morbidity hereditary diseases. Another problem is service does not have its own laboratory base for genetic diagnosis of orphan diseases. Organizational challenges, lack of a joint state registry for genetic registries. We don't have a registry for orphan patients and therefore don't have a registry for genomic tests. They are not part of the tariffs for medical services. So how we do it? Usually we send it abroad. It is paid by either big pharma companies, patients themselves, or charity foundations. It is done outside our country, and therefore we don't have the statistics for genetic tests. Economical challenges, high cost of genetic studies, social challenges, higher level of children disability, legal challenges, lack of regulatory basis, gaps in the regulatory base, and research challenges. Lack of genome diagnostics as a system in our country does not permit us to develop our research, and healthcare research bases cannot evolve, therefore. So our key problem here is quite addressable. I truly believe it is addressable. The biggest problem, lack of specific data, therefore no planning, no evidence for the need, for the unmet need, and therefore no financing allocated through insurance medicine. And to complete my presentation, my last slide, future prospects that I have already mentioned to some extent, development of diagnostics infrastructure, development of Kazakhstan test systems based on our National Center for Biotechnology, creation and support of medical nutrition products in the regulatory basis. It is mandatory to include more nosologies in the newborn screening. Also, 2 or 3 interregional centers are required for genetic diagnostic for orphan diseases financed from the state. They must be financed from the state. The main thing is to improve our registry capability for orphan patients, improvement of regulatory basis, development of education and human resources potential, because none of our medical universities actually educates neither geneticists or bioinformatics specialists. And the mandatory prerequisite for reliability of genetic diagnostics is the external quality control system. It is mandatory, and we truly hope and attach great hopes to that. We hope for the international partnership to help us address these problems in diagnosis and treatment of orphan diseases. Thank you for your attention.
Thank you, Prof. Gulnara, for this very informative talk. And yeah, indeed, I mean, challenges are present everywhere. And I mean, if you allow me, I will ask the first question, and then we see if we have other questions. And my question is related to your society, the Association of Medical Geneticists. So how can this association help in addressing all these challenges? What is the role of this association, and how you can help in solving some of these issues?
Thank you very much for this question. Our association is already, in this year, we are going to celebrate 26 years of our existence, and the main purpose of our association is education. Ongoing education for geneticists, doctors, those clinicians who are directly facing our orphan patients. And this is also education and training for our young doctors in internship programs, creation of various information materials. We organize annual trainings. Also, we have a regular regional level training where we go to our oblasts, our regions, where we meet with the primary medical care doctors, educating them. And also we have our annual republic level conferences, to which we invite you to visit them. The nearest conference will take place in June 3 and 4 in Almaty city. Yes, this is the brief information about this conference, but I think that the Association of Medical Geneticists is always the first in the introduction of any breakthrough medical technology or medical research. Thank you.
Thank you, Prof. Thank you very much. Indeed, like education and raise awareness is very important among physicians and among publics, and our leaders also. They always need to be informed about the importance and significance of these conditions, and how we can deal with them in a better way to provide better care for these patients. Do we have other questions for Prof. Gulnara before we move to the next speaker? Okay, so please allow me to introduce Prof. Ambreen Fatima. She's a professor of genetics at Aga Khan University, Karachi, Pakistan. And I think what she's going to discuss is very relevant to many parts of the world where we have high consanguinity rates. So now we will see the Pakistani experience from discovery to diagnosis, addressing rare genetic diseases in consanguineous population. So, Prof. Ambreen, the floor is yours.
Hello, everyone. Good morning. Can you hear me?
Yes, we do.
Okay. Thank you very much for the introduction, and thank you very much for the invitation. So I was actually listening to Dr. Gulnara's talk, and I was like, we have all this problem, but beside that, I'm going to talk about a little bit more on discovery of novel genes and kind of research-based diagnosis, because of course, I will start with our population and challenges, and then how we are kind of the model system that we are doing in Pakistan. So I have nothing to disclose. This is my institute in Karachi. That is one of the largest city of Pakistan. So this is a university hospital I'm working in. It's Aga Khan University Hospital. So I'll start with Pakistani population, and we are the fifth most populous country with quite overwhelmingly young population and very rapid expansion of population that we have seen over the last 6 decades. But what makes us unique in terms of genetics is in fact, highest rate of consanguinity, even more than a lot of countries, other Muslim countries, and even in the countries in Middle East. So we have more than 65 to 70% consanguinity, and actually in some of the regions, this is even more. And on the top of it, we have a lot of endogamy, that is ethnicity-based and the language-based or religious practice-based endogamy, and that, of course, add into the risk of a recessive condition even more than add top on the consanguinity. With this quite high burden of recessive condition that we have, still genomics is really low priority in the healthcare system, and it's not really a part of mainstream medicine. There are a couple of reasons. So one is that we have quite visible burden of malnutrition and infectious diseases. So classically, a lot of work that people were doing on malnutrition and infectious diseases. We do not have any national newborn screening program. We have at Aga Khan, we have started now a newborn screening for some of metabolic condition, but not really like for all. And that's why a lot of neonatal and infant mortality actually goes unnoticed and unrecognized in our country. Since the genomic medicine is not part of healthcare system, so genetic testing is considered as a luxury, and we do not have like a lot of, it is paid by patient own pocket, or otherwise they take part on any research initiative that I'm going to talk to you later. As Dr. Gulnara was saying, so we do not have genomics as a part of medical curriculum, so we do not have any residency or fellowship program in genomics, and that's why the poor genomic literacy we see in our public and healthcare workforce. Just how wonderful this resource or the population is, I'll just take a minute and talk about it. And we all know that the inbred population have 10 times more runs of homozygosity, and that have been proven, like this is a recent paper from Middle East, and that show that how wonderful this resource is to actually increase the magnitude of identifying genes those are not yet identified. And even though we do not have a lot of like research going on in Pakistan, but traditionally we have contributed a lot in novel gene discovery from Pakistan. So, and I think I would just talk about another wonderful resource that came from Pakistani population. In fact, this is one of the landmark paper that was published a couple of years ago on human knockouts. And of course, suddenly it got interest of all the pharma industry and different companies. And so this is again showing that how big magnitude we have to identify human knockout in consanguineous population. And so far, they have sequenced about 80,000 Pakistani individuals, and they have identified more than 14,000 knockouts for 5,000 genes. And if we want to actually establish the same resource from European individual, we need to sequence 11 million individual as compared to 80,000 from Pakistani. So now I will just quickly talk about the 3 models that we are doing in Pakistan in terms of rare disorders. So one and the classical and old model is the community-based research model. So this is mostly like researcher going, not the medical doctors, but researcher going into those communities. And since the burden is high, another factor that we have in our population is a large family size. So you see a large pedigrees with multiple affected individual. Those are easily recognizable. So then they are doing recruitment, those individual doing sequencing, mostly in collaboration with the other like European and other countries. And then we are doing a lot of reverse phenotyping, and the previous papers that I have shown you mostly coming from this community-based research model that we follow in our country. Now we have another clinical research model, and this is like clinician directly working with diagnostic companies or international collaborators and sending them patient samples. And then this have been also quite wonderful in terms of getting these families a diagnosis. So and now because of high consanguinity, it's not surprisingly that we see a lot of multivariant phenotypes in our population, and there are some data that is coming from these kind of research model and showing us that how many secondary findings actually we have in our population. Quite recent model that we have now in our country is a clinical genetics model for rest of the country. So it's like clinician sending their patient to geneticist. And this model, actually, we have only maybe couple of hospital in the entire country. Those are practicing, because again, we do not have trained clinical geneticists in our country. But because of the resources, this is like a model that is outsourced to the commercial labs, and this is paid by the patients from their patients' own pocket. So it's but they are getting now the genomic literacy is slightly getting better, and then people are interested in getting their genetic diagnosis done. So now I will switch to like for the last next 5 minutes to and I'll talk about our neurodevelopmental cohort, because I'm interested in neurodevelopment from the diagnosis to the gene discovery and disease modeling. So we have been recruiting these families from communities, as well as coming from the neurologists where the family cannot afford. So they refer their patient to us to enroll in the research project that we have. So after clinical data and the recruitment, so we do exome sequencing only on proband as first, and then try to look for the segregation, because of course we cannot afford trios or sequencing multiple individual because of the limited resources that we have. So the pipeline is quite straightforward, as most of the rare disease researchers are following. And then if we have the diagnosis, like likely pathogenic or pathogenic variant, we have made a system where we provide a report back to the family, and we of course give them carrier screening, and as well as like because we have mostly large families, so we try to give them the carrier status of extended family member that are enrolled in our research. The phase 3 is really on the discovery angle, where we have new genes, or sometimes we have novel variant in well-characterized gene, but it's a VUS, so we try to look and reclassify those. So, and we of course share everything on the gene matcher, and then of course go for the disease modeling. So this is our cohort. This is a map of Pakistan and showing how diverse we are in terms of language and ethnic background. So this is, so far we have what our cohort represent. Of course, some of the communities are overrepresented in our data set, but we are trying to make it more populated and trying to get recruit others. And the idea behind this is that we want to also look at the founder variant. Those are running in a lot of ethnic background, and maybe we can in future try to kind of do carrier screening in those communities for those founder variants. So far we have recruited more than 650 families, and again you can see the evidence of consanguinity is quite high. It's like 78% of families are consanguineous, 55% are multiplex, and as any neurodevelopmental cohort, we have quite heterogeneous cohort and quite large families going. Some families are of 31 individuals that we have recruited in our data. I will be just quickly telling that just with the proband sequencing, we were able to give 34% diagnostic yield and for the segregation analysis for the known for the known gene. But we have a lot of VUSs in known gene as well as in uncharacterized gene. But one of the area in with the standpoint of discovery, we have 13% of our family have biallelic loss of function in those we are the potential candidate gene for disease modeling. And what we have, even though it's quite small cohort, but we could see that these are mostly coming from the communities, those are underrepresented. So underrepresentation is kind of a predictor of a novel gene discovery in those communities. I will be, I know because of the time limitation, I'll be just quickly going through that. We have a system in-house in our lab where we reclassify VUS in known gene. For example, this is like a founder variant in 3 families. Then we have, it was a missense variant, we have reclassified a likely pathogenic variant. And then there are some where we have like VUSs in known uncharacterized genes. So we try to do functional of those. And one of this is a novel gene that we have identified in our cohort. We have more than 34 loss of function biallelic genes. So this is one of them. We found 2 other families from Gene Matcher. Look at the cellular level. This is a cholesterol transport related gene. And then also we have made a zebrafish model in collaboration with Erica Davis from Chicago. And we could see in the mouse, in our zebrafish model that have a, neuroanatomical changes. Those are similar to what we have seen in our patient. And of course, we have seen some interesting pathway related to neurodevelopment in our transcriptomic data. So this is just a proof of concept that what knockout we have identified. So now we are actually looking for their functional. This is another wonderful story that is our recent, one of our DDIS genes that is involved in DNA repair mechanism. So again, how like even from a small cohort, the discoveries that we are getting is like tremendous. And as compared to other cohort like deciphering developmental disorder in UK and other similar cohort, although our number are quite small, but the magnitude of discovery is quite high. So I will end that the consanguineous and historically underrepresented population still hold a huge potential when we think that, okay, gene discovery is probably kind of saturated, but maybe we are not looking at the right population. So those are actually a unique resource for discovering remaining genes in neurodevelopmental and of course for other diseases as well. Of course, minimum, but the focus phenotyping still yield a lot strong genetic diagnosis, although a lot of our families are relying on the reverse phenotyping, especially if they are coming from the communities, those do not have access to a neurologist or developmental pediatrician. As earlier speaker have said, international collaboration is probably the key, and especially for communities like us or the countries like us where we have limited resources. So yeah, this is my group, and I have some funding agencies, and of course, I'm thankful to the patient and their families. And yeah, thank you very much. I hope I'm on time.
Yes, thank you. Thank you very much, Prof. Ambreen. It was really very exciting talk, and we learned a lot. And this is like an example of how we can, sometimes if we have limited resources, then we can use actually the research to help in providing answers for patients. If we don't have genetics lab, then maybe we can utilize the research and really find diagnosis for individuals, at the same time discovering new genes. This is amazing. Do we have questions for Prof. Ambreen? Maybe you have time for one quick question.
If I may ask the question, yes, thank you very much, Professor Fatima. It has been very interesting for me. You have done a tremendous amount of job having this very limited resources. It's very difficult to conduct this kind of research. I represent Uzbekistan. I will introduce myself further on. We also have this consanguinity problem. Well, you have 65 or 70%. That's very high. We also have this problem. Well, in our country, we are trying to do something at the regulatory level to adopt a law on forbidding consanguinity marriages. We are still thinking about this. So what is your experience? Are you doing something in this direction, or your mentality does not permit that? What do you do about consanguinity?
Thank you very much for asking this question. I think we have been thinking about, for instance, thalassemia is one of the most common that we see in our country. And now we see a lot of families, those are not cousin, because we have the carrier rate is quite high in our population, right? So we have made certain kind of law and regulatory things around that, but those are not going to work, and those have not really worked. And so I believe that it's more on educating them first, and that is the key, because if we have law, and probably that will not be practiced. So we are now working for like couple of projects where we are working closely with our religious leader, with our community leaders, and trying to understand. And then, of course, once we have the better understanding, because even different communities have different explanation of practicing cousin marriages, and this is like deep-rooted culture, right? It's not just practice like couple of decades ago. This is like a part of our tradition and culture. So we are working on that and first trying to understand and what are the priorities, and then we are actually trying to maybe shortlist some of the priorities and work closely with these stakeholders that are community leaders and religious leaders and families. Those have been diagnosed and undiagnosed. So hopefully in future we'll have something around that. So we are working on that as well.
Thank you, Prof. Ambreen. Again, I mean, this
Огромное
emphasizes.
спасибо, профессор Амбрин.
Yeah, yeah. So this actually.
Это
Okay. Yes, thank you, Prof. Ambreen. This also actually emphasizes the need for education, not only for healthcare providers, but also for public and for stakeholders and leaders. So thank you very much. Now we will move from Pakistan to Turkey. And we have another very interesting talk from Prof. Fatmahan Atalar. She's a professor at the Faculty of Medicine, Department of Pediatrics in Istanbul University. Also, she's part of the Rare Disease Research Laboratory, Institute of Child Health, Division of Rare Diseases in Turkey. And Prof. Atalar will give us a very exciting talk, and the title is also interesting, Better Time Sequencing, a CIS 3D implementation model for rare disease genomics. So it seems that Prof. Atalar has already an excellent plan, and we are looking forward to hear your presentation. The floor is yours, Prof.
Okay. Good morning. Can you see my slide?
Yes, we can.
Yes. Okay. So good morning, esteemed colleagues and partners of the CIS Orphan Forum. It's a pleasure to be here with you today. My talk is titled Better Time Sequencing, a CIS-ready implementation model for rare disease genomics. My central message is simple. Rare disease genomics will not be transformed only by sequencing more patients, but by placing the right sequencing test at the right clinical moment after a meaningful signal and early enough to change care. So this is me, and I will begin with why rare diseases have moved from awareness to implementation. So rare disease genomics has actually entered the implementation era. The challenge is no longer sequencing itself, but placing sequencing at the right clinical moment. So Türkiye is a useful model because rare disease meets an existing screening foundation. The key question is how to turn the suspicion into timely molecular decision. So Türkiye is, as I said here, is a high-need rare disease setting shaped by both affected population size, which is around 5 to 6 million, and high consanguinity, which is around 23.5%. So a screening result or biochemical abnormality may already suggest that something is wrong, but suspicion is not diagnosis. What is missing is a rapid, affordable, governed confirmation bridge between the first signal and the molecular answer. Yes. Yes, the bottleneck. Yes, Turkey already has a strong newborn screening foundation initiated in 1987 with PKU, and now we are screening 6 disorders, and we have added SMA in 2022, and we have also established our own first national rare disease action plan in 2023, which is going to be lasting in 2027. Well, I mean, of course, this newborn screening foundation gives us early entry point into rare disease diagnosis. But screening success creates responsibility. A positive biochemical signal actually must lead to rapid molecular confirmation, not another diagnostic odyssey. So as newborn screening expands, which we all want, so the key question is how to make sure it leads to diagnosis but not uncertainty. So the question is no longer can we sequence, but you know, I mean, there is a clear, I mean, shared ambition, I mean, in all countries to expand newborn screening. Some already did, but we are in the process of expanding, you know, our screening panel. But expansion only becomes clinically useful if suspicious biochemical signals can be confirmed rapidly and affordably. So the bottleneck is not detection alone, but confirmation. This is where targeted Oxford nanopore sequencing enters the pathway, and not as broad sequencing for everyone, but as a clinically timed second-tier confirmatory layer after a meaningful screening signal. Yes, we are all familiar with Homer and also, I mean, the Odyssey. But today we all use, you know, the diagnostic Odyssey to define a clinical harm pathway. So in this case, in this particular case, the child has symptoms for years with progressive muscle weakness, delayed motor development, and but unfortunately, you know, I mean, it took him years to reach the final molecular answer. So almost 7 years it took him or the family, despite multiple visits, you know, to hospitals and the misdirected tests that they have gone through. So the problem was not actually, you know, lack of medicine. The problem was the right molecular test was not used at the right time for this child. So this is the clinical gap, that a better timed second-tier molecular confirmation layer is designed to close. So here, of course, you know, the delays. Yes, the delay also has an economical and dimension, and also equity dimension. So this slide actually shows what happens when testing becomes a sequential guessing. Several partial tests accumulate cost before the correct molecular route is reached. This is on the left-hand side of my slide. But the larger problem is also access. So higher cost genomic routes reduce availability, especially in regions where the income and diagnostic access are already unequal, which is the case in my country. So this is why a focused second-tier confirmation pathway matters. So targeted ONT confirmation can provide an earlier molecular answer at a more realistic cost before broad escalation is needed. So the goal is not more testing in my case, the goal is the right test at the right time. So, yes, targeted ONT data become clinically useful only when interpreted within the biochemical context. So we can't really, dismiss that. Our in-house pipeline, which we are already built, our bioinformatic pipeline, combines this context with variant quality, with read support, and inheritance logic. This is gene relevance and CNV, SV triage before expert review. So the goal is not more variants, because it's timely, and this will delay, the patient or the family, reaching the diagnosis as well as the clinician, of course. So the goal is not, is a clinically meaningful molecular decision. Yes, so I have this bridge. This is the proposed bridge. First, a screening of biochemical signal is recognized, and secondly, the targeted ONT confirmation is applied to the relevant disease pathway. Third, the result supports an immediate clinical decision. And so you may say that what's going to happen to the unresolved cases? Yes, the unresolved cases can then move rationally to broader, WES or VGS. So it gives the health system a disciplined middle layer, actually. So this model is strong because it has got boundaries. So it is not a universal newborn genome sequencing, but it is an indication-driven pathway-specific confirmation layer. So only genes linked to the clinical question should be interpreted in our case. So in genomics, discipline is not a limitation. So it is what makes the result clinically useful, actually. So this is where the concept becomes an operational essay. Following an MSMS positive screening result, genomic DNA is processed through a targeted confirmation workflow comprising probe-based hybrid capture enrichment, barcoded ONT sequencing, controlled bioinformatic interpretation, and clinical reporting. And our internal target after validation is approximately 2.5 days. So, to a control triage output, of course, don't confirm, exclude with assay limits, or escalate. So the point is not replacement, don't misunderstand, but timing. Targeted long read sequencing is used where rapid confirmation can change the pathway. Yes. My group's earlier ONT studies show that long-read sequencing can work reliably in defined single-gene and also multi-gene rare disease workflows. The fatty acid oxidation disorders probe-based multi-gene panel is the next step. So it moves us from disease-specific assays toward probe-based hybrid capture with broader adaptability. And improved, of course, coverage uniformity as well. So this is a platform development step towards scalable, governed metabolic confirmation. So in other words, Turkey's ONT journey actually is moving from disease-specific feasibility to a probe-based multi-gene confirmation architecture. So yes, let's come the affordability. So this method only becomes implementation a method when it can reach patient at a realistic cost. So with the target below $100, per patient, substantially below current, broad genomic costs, which costs arm and a leg, for all of us, for patients and also for the country. We are actually focusing, confirmation. We believe that the confirmation can make, expanded screening more actionable and sustainable for us. So yes, for the CIS region, this must be more than a Turkish laboratory story, of course. So a regional implementation model needs 6 pillars, I believe. One is the shared, biochemical to genealogic, local validation, training networks, quality system, data governance, and regional ownership. So without these pillars, the sequencing would remain a machine, but with them, it will become a clinical system, I believe. So the CIS principle is architecture without dependency. So which means the shared standards can travel across borders, but clinical responsibility must remain local. So each country actually should remain accountable to its patients. That is how collaboration becomes capacity, but not dependency. So, sequencing matters only if it changes timing and action. So, a report is not the end point, but a better clinical decision is the end point. So, better timed sequencing is therefore a care pathway. It's the signal, confirmation, decision, and action. So, this brings us to the regional outlook. How better timed sequencing can turn barriers into access. Yes, so for many high-need countries like Türkiye, the barrier is not simply absence of technology, as I've heard, from early, speakers. It is actually fragmented access, long turnaround time, inconsistent interpretation, and broad testing that may still miss the right clinical moment. So a rapid second-tier confirmation pathway can turn better time sequencing into an access strategy. To make this practical, we need a structured CIS-facing genomic partnership. So, to make this practical, we propose a CIS-facing genomic partnership built on shared QC, quality control metrics, pseudonymized, data sharing, joint pilots, studies, and training goals. So, while today I'm speaking in a CIS context, the same implementation logic can support broader regional partnerships, including MENA countries, facing similar rare disease, consanguinity, and newborn screening challenges. So we are all in the same boat. So Turkey can actually contribute as a project partner in targeted ONT confirmation workflows, bioinformatic governance, quality systems, and trainings. So the aim is shared standards, local capacity, and coordinated regional implementation. Yes, last but not least, rare disease genomics should be judged not by data volume, but by clinical timing. For Türkiye and the CIS region, better time sequencing means the right test after the right signal, early enough to change care and save many lives. And thank you very much for listening to me. And I also wish happy Eid Mubarak to all who are celebrating. Thank you very much.
Thank you very much, Prof. Atalar. This is really, yes, we need to change the way of thinking because, in our minds, the larger the better, right? The bigger the genes included in the panel, the better test. If you do exome, even better. If you do genome, even better. But now, I completely agree with you. We should really go one step back and start thinking about what is more beneficial, what can bring us faster answers at lower cost and more accuracy. And this is really, for me, it was very, very useful to hear. And maybe we need really to start rethinking about how we approach our patients from instead of doing wide and untargeted testing to more focus on targeting testing.
Yes,
This
this
is
is
great.
what we are
Thank you very much.
actually aiming to, to implement for our expanded newborn screening program. And because, as you said, you know, the escalated, the VGS or VEST, they are generating massive amount of data, and it takes days and weeks, you know, to be able to actually discover or to be able to analyze all this. And this is, it's a bioinformatician job, but again, one bioinformatician is not enough to do all this in my hospital. And so therefore, you know, we are also sending samples abroad, which is not, which we don't want to do it anymore, and we want to analyze our own data with our own pipeline, which will enable us, you know, to move, you know, freely and be independent. So this is what was the aim of this work, and this work actually initiated by the.
Thank you. Thank you very much, Professor Fatma Khan, for this very informative, very enlightening presentation, very much ready for implementation for genomic diagnosis of orphan diseases. So, dear participants of our session, unfortunately, we are went beyond our timeline. So I'm happy to give the floor to Professor Marhabo Shamsuddinova, Republican Specialized Research and Practical Center for the Health of Mother and Child, PhD medical doctor, president of the Association of Clinical Neurophysiologists and Medical Geneticists of Uzbekistan, the city of Tashkent. Please try to stick to the agenda because we are already lagging behind. Yes, good morning once again. Thanks to the organizers of this forum for their kind invitation. We are learning many new pieces of information. It's very important in the context of international collaboration. I will give you a brief review of the genetic testing landscape in Uzbekistan. I work in the Republican Special Science and Practical Medical Center for the Health of Mother and Child. It's mainly prenatal and newborn screening and medical genetic consulting. I'm the president of a very young association. We are only 1 year old, but we are hoping for future development and possibility to use your experience and to establish strong ties between our associations. Today we are talking a lot about orphan diseases, so I will skip the highlights that we all already know. Recently, there is a trend to sustainable increase in the number of diagnosed cases, which of course increases the burden for our healthcare system because they all require treatment, diagnosis, and also medical and social support for these newly discovered patients. Speaking about Uzbekistan statistics, we are 38 million people living in Uzbekistan, and based on average statistics, we have about 1.3 to 2.3 million people with orphan diseases. And orphan diseases are becoming also a medical and social problem, and also an economic challenge for every country. It's the same in every country, so it is important to meet each other, to discuss our experience, exchange opinions, and select the best way for every country, taking into account our specific features like mentality, culture, and so on. From the very beginning, we started our way in diagnosis of orphan diseases back in 1998. Here you can see the key regulatory documents on diagnosis of orphan diseases. Decree number 140 of the Council of Ministers back in 1998, a network of network of governmental screening centers was organized, and in 2023 they were integrated in the system of birth helping institutions. Now they are called Mother and Child Health Centers. We have these in every region of our country with neurologists, cytogeneticists, endocrinologists, doctors. It is indeed a multidisciplinary team, and a very important method in diagnosis was decree number 4440 back in 2019, where for the first time we prescribed the governmental program to treat 5 orphan diseases, and the decree number 331 is a logical follow-up to this. It was adopted last year, where the number of diagnosed orphan nosologists to be treated increased from 5 to 10, and of course the amount of money was also increased to cover the treatment costs. Another important decree is a decree of 2022 on the medical and social need to children with SMA and free of charge target therapy. Diagnosis, well, we are all moving toward earlier diagnosis, and here prenatal screening in Uzbekistan has been done since 1998, ultrasound and biochemical on first and second trimesters. Starting from 2007, we are making prenatal invasive diagnosis. In 2019, in every district, offices of prenatal diagnosis were opened, and every pregnant woman undergoes ultrasound screening no less than 3 times. Based on the results, she is referred to a more selective screening. As for newborn screening, it is done for phenylketonuria and hypothyreosis, and starting from 2025, newborn screening for mucoviscidosis was also started. We have all the necessary equipment with analyzers for FOAD screening, and also we have other genetic tests for mucoviscidosis. Also, we have pilot screenings for tandem mass spectrometry for lysosomal storage disorders from 2020, like Gaucher, Pompe, Niemann-Pick, Krabbe, Fabry diseases, organic aciduria since 2015, and also since 2020 we are doing audio screening for newborns. Postnatal diagnosis in our centers is accessible in the form of standard karyotyping and fish diagnosis for some syndromes like Williams and other syndromes in 5 large interregional clinics. We are trying to get as decentralized as possible, but unfortunately, molecular genetic diagnosis, as of today, there is not a single state laboratory that would be capable to do WES sequencing, WGS sequencing, and so on. Currently, we have a number of private labs that are equipped properly. And we also have an outsourcing system. We are working with these labs. Coverage comes from insurance, or sometimes patients pay from their own pocket. Taking into account that we have a high consanguinity rates in our country, we are trying to move towards a premarital screening, and recently we started to see a trend where reproductive couples, before the conception or even before the marriage, they come to our geneticists. Have a greater number of couples visits geneticists for the screening. Premarital screening for SMA has been prescribed, but so far it is selective and voluntary, and people pay for it from their pockets so far. Also, auxiliary reproductive technologies are applied, and these families, if they know that there are this potential is there, they choose frequently to perform this screening, undergo this screening. There is a number of orphan centers with multidisciplinary teams and target therapy, and also registry management, because it is very important to have registries to know the real situation for the existing diseases, to be able to come up with a kind of strategy. in the Mother and Child Health Center, as well as in 14 regional affiliates, inborn hypothyreosis is screened for. There is a registry for PCO with free of charge special nutrition aid, SMA registry. Also, Resdiplom is provided. Also, Duchenne muscular dystrophy. Starting from this year, every patient will be provided with thyroid therapy in the form of biflazocort. Also, there are 14 regional pediatric centers for patients with mucoviscidosis who are receiving nutrition, special nutrition. Same for Pompe disease. Enzyme replacement therapy, same for Gaucher disease, and also our specialists in this center have now mastered special methods for introduction of intrathecal injection for SMA patients. Also deafness, inborn deafness are also receiving help here, also diagnosis and treatment for patients with juvenile rheumatoid arthritis. Also in the National Medical Center, unfortunately, we started to have this problem with subacute panencephalitis, sclerotizing panencephalitis. Also specialized nutrition is provided there. Fermentology and enzymes, the research center also has a register for patients with bullous epidermolysis, also providing special care there. Also, our Center for Hematology maintains a hemophilia patient registry with factors 8 and 9, and also registry of thalassemia patients. Distinguished Mirhabo Anvarovna, let me remind you that your time has almost expired, but you are allowed 2 more minutes. 2 more minutes. This is my one before last slide. And also the register with primary immunodeficiencies. And here is data for the registries. You can see the number of patients with certain nosologies. And according to these figures, we provide necessary therapy for the patients. SMA, for example, total SMA, we can see the incremental number of detected patients thanks to better diagnosis and survival of the patients. Only 65 patients back then, and now it's more than 200. Of course, to summarize, these technologies improve detection rate. The use of therapy improves survival. However, there is a problem of underdiagnosis in remote regions. Treatment reduces disability rates, but it is higher burden on the budget and healthcare system, which requires introduction of preventive measures because our country has limited resources too. And what we suggest is to come up with a national center with a proper lab. Unfortunately, we don't have this. And the expansion of the program, we are planning a pilot project for SMA newborn screening, and also to enhance accessibility of new test methods like NGS, WS, and so on, and also introduce a system of advisory medical advice for the patients, and also expand our collaboration with the leading experts of international countries in the area of diagnosis of orphan diseases. Thank you for your attention. I will be happy to answer questions. Thank you very much, Dr. Mirhabo. Of course, we have questions, but unfortunately, we don't have time for the questions to discuss them. So, well, maybe we will have time for Q&A discussion towards the end of our session. So now I am happy to give the floor to Dr. Oksana Pribushenia, Doctor of Medical Science and Professor of the Medical Genetics Laboratory for Monitoring of Inherent Malformations of the Mother and Child Practical Research and Practical Center. We talked a lot about the need for registries, and also Dr. Shamsidinova mentioned that. So We are going to hear about the National Registry of Inborn Malformations in the Republic of Belarus. The presentation will be a recorded presentation. Good afternoon or good morning, dear colleagues. Thank you very much for this possibility to speak today at the Orphan Forum. I would like to share with you some information about operation of our National Registry for Inborn Malformations that enables to evaluate the quality of screenings in the Republic of Belarus. I will give you a quick review of our medical genetic programs. And here, Medical Genetic Service of the Republic of Belarus is not only working with orphan patients, not only monitoring of inborn malformations, but also all the types of prenatal studies to identify an inborn pathology of the fetus. The foundation for the results that we achieved is a specific feature of administrative governance in Belarus. We have a small population, rather small population, with a moderate density of population and very high percentage of city population, of urban population, low birth rate, and also low infant mortality. We are a mono-national country, mono-religious country. 33% of our population have a higher education, which enables us to easily perform some administrative and organizational work to organize population-wide screenings. The whole territory is covered with perinatal centers, and also every center has a medical and genetical department. For this center, either part of the center or an individual entity, like in the town of Gomel, for example. And the Republican Science and Practical Center, Mother and Child, is the core element here. Perinatal diagnosis of inborn diseases. We have also two research laboratories to perform genetic studies. The key areas of activity of our genetic service is prenatal diagnosis, pathomorphology diagnosis, confirmation of initial diagnosis, newborn screening, and treatment for children with different hereditary diseases, also diagnosis of hereditary diseases, and follow-up for inborn malformations. This monitoring has been in function since 1979. It covers the whole territory of our country. 3 phases of registration occurred here. First of all, the ones that were registered at the time of birth, then before 1 year of age, and then before 18 years of age. It includes various chromosomal disorders, minor anomalies. So-called minor anomalies are not registered without proper combination. We have a special software, quite comfortable to use, quite friendly. It has the main spreadsheet, 20 list-based spreadsheets, and 21 spreadsheet with encoding. We can analyze the structure and the trends depending on specific region, and also analyze the factors that might have had an impact on the changes of the incidence of a certain defect, genetic defect. The average statistics is 31 promille and 22.9 promille. Prenatal screening in Belarus has been there for 36 years. At the first phase, we do a combined screening for pregnant women. Second phase is ultrasound of the fetus to identify inborn malformations. If there is an additional test needed, like MRI, for example, we can make it. Invasive procedures are done in the first trimester and in the second trimester for amniocentesis. Classic cytogenetic tests are also done for 500 bands. If there is a need in prenatal studies, we have a chromosomal micromatrix analysis. Of course, what matters is the availability. T21 cutoff is 1 to 360, one of the most stringent thresholds, and we can screen for 98% of pregnant women in the whole population. Last year, we screened 93% of all pregnant women because we did have some administrative issues here. Transportation sometimes was not readily accessible. 4.4% was the high risk group, and the 89% was the sensitivity of the screening in last year. The risk group is only 4.4%, but we have somewhat broader coverage in invasive procedures because there are some other indications. Sometimes we screen according to the age of the pregnant women. 6% of invasive procedures enabled us to have quite a high detection rate of chromosomal disorders. Every 15th procedure has become effective, and 1 out of 30 cases actually resulted in a Down syndrome being detected. So the statistics in Down syndrome shows us that thanks to this screening, the detection rate is increasing because the average pregnancy age is growing. Age above 35% is 22% in the country and 28% in the town of Minsk. And 1/3 is active preservation of all pregnancies. So we can preserve active pregnancy with quite high success rates, even those pregnancies that might have been lost otherwise. And overall statistics for Down syndrome was 1 out of 380. The red trend keeps being stable, which is the rate of Down syndrome in the overall birth rate. Here, the red line is the contribution of prenatal diagnosis. So we can see that it works quite sustainably despite the overall increase in the detection rate of Down syndrome. We analyzed all the registered chromosomal abnormalities in recent 5 years. It amounted to 1,266 cases, same as in 2025. In most cases, the pregnancy is prematurely terminated, but our objective is to study the live birth cases if the pathology is identified. Overall amount of termination was 625 in previous year. Of those with inborn chromosomal malformations, the live births were 242, and more than 20 of them were with high disability probabilities. Infant mortality is very low. It was only 2.4 per mille in previous year, and we analyze the contribution of inborn malformations into this infancy mortality. It is shown here as a contribution in general downgoing trend. A lot of attention is paid to prevention of inborn malformations. Monitoring of these enables us to see how the prevention activities with folic acid, for example, helps, and we can see the trends of the defects of the nervous tube. We all know this story, folic acid and nervous tube connection. 30 years ago, defects of the nervous tube contributed to 2.7 per mille in overall statistics, or 0.9 per mille among live births. In 1996, we started to have preconception vitamin prophylaxis, and as a result, in 30 years, we have a reduction in the nervous tube defects by a factor of 2.7, and among live births, this incidence rate is stable at the level of 0.1 per mille. Also, you can see a stable trend for orofacial ratios and inborn heart malformations. We performed this analysis on folic acid prophylaxis, on the prevention of some inborn malformations. we did not have any changes in the orofacial gaps or inborn cardiac malformations. Organizational measures on prevention, of course, periconceptional prevention with folic acid at the time of planned pregnancy, and the second tier is better identification and diagnosis capabilities, also education for the medical care specialists, and also fine-tuning etiology with laboratory methods. Third level is correction of inborn malformations, neonatal screening, surgical correction, symptomatic therapy, and rehabilitation. Thank you for your attention, and I will be ready to answer your questions. Thank you very much, Dr. Pribushena, Dr. Oksana, for this very informative example. Indeed, there in Belarus, we have this post-Soviet, Soviet very stringent system for neonatal screening, which is one of the best screening systems in CIS countries. And our next speaker is, well, with great pleasure, I am giving the floor to Dr. Sergei Voronin, the chief doctor of the Bochkov Academician Medico-Genetics Center, the main specialist of the Ministry of Health of Russia in the Far Eastern Federal District, Moscow, Russian Federation. Dr. Voronin will share with us valuable, very valuable Russian experience in organization system for orphan diseases and generally in genetic diagnosis. Would you please make sure that you select the Russian channel on your computer? It's either globe or three-dot bottom, and then you will have to select More, Translation, and select Russian. Just give me one moment. We are ready to hear you endlessly, but we have a limited timeline. You only have 15 minutes for your presentation. So it was your excellent English that the Russian audience heard, or was it the interpreter? Okay, sound check. Okay, I will keep speaking Russian with the English translation. Yes, yes, sure, thank you. But you actually expressed, you impressed me greatly with your English. Okay, I will continue to speak Russian, but it's true that I'm very happy to see everyone here, to see our international guests at this very important event. And here we have an opportunity to tell you about our current situation, our current challenges that are of extreme importance, and I'm going to share my slides now. So here are my slides. Diagnosis, treatment, and prophylaxis and prevention of orphan diseases is extremely important, but it all starts with diagnosis. Premarital consulting with testing for mutations, extracorporeal procedures, and then neonatal screening, and altogether the system that works in the Russian Federation. We have a three-tier system. We have 89 regions, subject regions in the Russian Federation, and in most of them there is a so-called primary and secondary genetic consultation institutions that provide medical advice and prenatal screening, more than 70 consulting offices like this. Also, we have 10 centers of what we call 3A group with expanded neonatal screening, and Kulakov Center, Group 3B, is really leading the way here. Speaking about neonatal screening, newborn screening, there is a number of phases here. The first phase is 1993, when we started to test for phenylketonuria and inborn hypothyreosis. In 2006, we added 3 more nosologies: mucoviscidosis, galactosemia, and the third nosology. And as of 2022, we made what we call expanded newborn screening, and this expanded newborn screening covers SMA and primary immunodeficiencies, and also 29 other inherited diseases studied by tandem mass spectrometry. Also, we organized this system. If we speak about conventional newborn screening, it exists almost in every subject region of the Russian Federation. Speaking about expanded newborn screening, primary tests is done in 1 out of 10 centers that we can see on the slide. So what has changed for us since 2023? We changed the timeline. The timeline is very short, very strict now. Blood tests is done in 24 hours in term pregnancies, live births, and on a bit longer on prematurely born children. And we have 3A category centers where we have TMS method, one conventional newborn screening, which is done within 72 hours. It's quite fast. Then during 1 day, 24 hours, we transmit this information that this particular newborn is in a risk group, and then there is another 24 hours to take a sample and to bring it to the medical diagnostic center, where genomic tests will be done, TMS test will be done, and some other test methods that are required for the final diagnosis. After that, if there is a diagnosis of an hereditary disease, we inform the regional clinic, regional healthcare system, and then within 24 hours, a federal concilium, federal board is organized using telemedicine, means within 24 hours. So therefore, we can achieve the following. Currently, SMA for maturely born child, we can diagnose it within 9 or 10 days of life of this child. We can confirm the final diagnosis despite the vast distances that exist in our country. Thanks to the streamlined work at every layer, so-called roadmaps that cover all the logistics and control points, we managed to drive down the term of initiation of SMA therapy by a factor of 2, to shorten it by a factor of 2, starting from the 60 days. I'm talking about abiprovavir genetic therapy drug, which is not manufactured in Russia, but we import it from abroad. And for this SMA, it's not a 60-day, but day 30 or day 35. And for other methods of SMA therapy, it can start in the very first days of life. This is a huge achievement for us, but we are still trying to shorten it further. The day to the therapy, the time to the therapy initiation. The results of our screening in 3 recent years, I mean the expanded screening, the coverage of newborns amounts to 98% and even more, a bit more than 100 in 2025, but this is the kind of tail that we inherited from the previous year, 2024, with the 1,200,000 of newborns. We can see the statistics here, and further on we will continue these detection rates. You can see 1.85 is the detection using TMC TMS and PCR methods, including the non-resident children who are not citizens of the Russian Federation, but this is done free of charge. It is reimbursed from the federal and regional budget. We will never reach 100%. Unfortunately, not all children survive, and there are also non-resident children who came for this test to Russia and then migrate back to their countries. But what we have achieved is the detection rate. The detection rate is going up steadily. It is still below the desired level. We can see some specific features for SMA, for example. Line 2, we expected 1 out of 7,000, but so far we can see only 1 out of 7,000 in 2024. But in 2025, this rate has gone up again. But we are working on this. Screening is not a dogma, not an axiom. We continue to improve it. Biotinidase shortage was also screened for, pilot in 2024-25, ADAT severe immunodeficiency in 2025, also X-linked adrenal leukodystrophy, and deficiency of decarboxylase of aromatic L-amino acid in this year. Duchenne myodystrophy is planned for Q4 this year, and also lysosome storage disease in the next year, like Fabry, Gaucher, Krabbe, Pompe diseases, and others. It will be a mass screening. Non-selective, we will cover 99% and more, but diagnosis is only half of the problem. But this half of the problem has been almost fully addressed thanks to the Presidential Charity Foundation, the Circle of Kindness. Here you can see how we are doing this with the help of the Circle of Kindness Foundation for regional programs. We provide treatment for patients up to 18 years old for 110 diseases, including mucoviscidosis, mucopolysaccharidosis, SMA, and many others. 30,000 children are taken care of by this charity foundation, Circle of Kindness. It is a presidential program that is financed through 2% of additional taxation for very wealthy people with very high income. More than 200 billion rubles was spent in 2024 for orphan pathology patients, and also 31 billion was spent for these patients only through the Circle of Kindness Charity Foundation. Also, we have a federal program that provides medical care for 133 nosologists and also other groups of care. Of course, we understand that newborn screening can never address all the problems of hereditary diseases. There are patients who were born before 2023 from the same groups. We have also our adult patients. We also patients who were born in the expanded newborn screening era, but still they were missed. There are some point mutations, deletion of 7 and 8 exon. For example, there are people who reject genetic tests, not many of them, but still they exist. And we have a problem of underdiagnosis. We know about it. We are working to improve it, establishing quality control systems and safety control systems. So that's about newborn screening, but we also understand that there are selective programs, research diagnosis programs that enable to find out patients with clinical manifestations that were not diagnosed during the newborn screening. We have patients like that. Altogether, there are 42 research diagnosis programs that cover patients with many diverse hereditary diseases without the need to come to our Bochkov Center. And out of the 7,000 hereditary diseases, patients have a right to have free of charge medical care, to have a test in medical institutions. Of course, our joint goal is prevention, primary and secondary prevention. And here in the Russian Federation, following the decree of the president, starting from 2026, from the budgetary financing, we are starting a screening for monogene diseases and structural translocation diseases. This is for extracorporeal fertilization children. We have prenatal screening, like everyone has, and here the coverage is more than 90%. We have ultrasound for fetuses studies that helps us to build up the risk group. But similarly to other colleagues, we know the problems of rejections and hypodiagnosis due to incorrect ultrasound and some other reasons for underdiagnosis. And to address this challenge, starting from this year, we have a mass screening for the studies of extracellular DNA in the mother's blood, invasive perinatal screening that will be reimbursed through mandatory medical insurance. This is what the companies, the employers pay to the federal budget. So we are starting to analyze, first of all, pathologies with trisomia 20 of 21st chromosome and the 2 other chromosomes. 3 to begin with, then we will expand it. Nevertheless, despite the existing problems, you can see the territory of our country, 10 time zones, several thousand kilometers. We were told you are bound to have logistics problems if we have only 10 centers to make study in. If we look at the Siberian part of our country, we have Kamchatka Peninsula, the easternmost location of our country, 9,000 kilometers, 9 hours of flight, 9 time zones. The time from blood intake to the laboratory in the Moscow Medical Genetics Center is 18.5 hours. We managed to organize this logistics, and thanks to that, we understand that we will be able to achieve a lot. We are developing information technologies, and currently we are introducing digital technologies for reference information and AI elements. We are building up registries and databases for specific hereditary nosologies. We have a number of mandatory registries, a registry which is called 24VZN. Also, currently at the website of the Ministry of Health, we have a registry with 302 hereditary diseases and nosology groups, not all of them so far, but we need to start something, to begin with something. And then we are also developing special modules, so-called vertically integrated medical information system, which we will continue to build up, and also a very broad introduction of the system. We understand that screening is very important. It enables us to do a lot. But nevertheless, we are continuing to improve awareness in communities, in our society. So newborn screening is not equal to no disease. So we are always trying to improve detection rate. And on top of medical, social, and other dimensions, we also have economic dimension, economic consequences, and economic benefit. Yes, we need to speak about this, taking into account the price of orphan diseases. We need to think about the economy as well. We are doing a lot, and we are hoping that together we're making the world a better place. Thank you very much. Yes, you are really a gem in our today's session. You impressed us with your excellent English and also your excellent system of organization of screening, diagnosis, and treatment of hereditary diseases. We have very little time left, but still I will permit myself to ask a very quick question, just for myself. The biggest highlight for myself in your presentation is that you were able to build up a decentralization system, that you have interregional centers. And my question will be, indeed, distance is enormous, but what models work better? Creation of a full-scale genetic labs in every big city, or a system with one federal center which collects data from all Russia very quickly. In fact, what we see is that it should be a comprehensive system, a holistic approach. If it's regular test for the 5 nosologies that we are currently doing using fluorometry, we can do it at the level of any subject region. It does not require any high qualification or expertise. But if it is a TMS method, then it does require a different level of expertise. So we are centralizing the tests that require this high technology knowledge and high level of skills. The next transition level is NGS, and we understand very well that ideally, sooner or later, every geneticist doctor will be able to do information analysis based on this. Currently, most of our geneticists are clinicians who can do it very well, with the biochemical phenotype, set a diagnosis, and then send it to one of the federal centers. We also understand that the greater the number of studies, the lower the cost of every individual test. And taking into account that we want to talk about big coverage, vast coverage, we have to talk about economics. You heard that from the time of blood sample taken in Kamchatka to Moscow analysis, it's 18 hours. This speed is more than enough in most cases. Thank you. Thank you very much, Dr. Voronin. So the work of our section is completed. So let me really quickly make this conclusion. First of all, we are extremely thankful to all speakers for their very professional contributions. Thanks a lot to distinguished audience for your attention. 8 speakers participated in our session, representing 8 different countries, who presented their approaches to genetic technology and care for patients with rare diseases. They shared their problems and their solutions. And as for myself, I will take just a couple of minutes. I'm imagining for myself, if I was asked a question, or any of you was asked a question, what is the single achievement from every country, from every speaker who presented today? I would dare to say that, first of all, the presentation about MENA region, what we would adopt in our country, for example. Well, oil dollars, somebody is hinting, oil dollars, petrodollars. Well, this is also important. Finance is also important because it expands your capabilities for genomic technologies as well. But what I could take from Pakistani experience, Professor said very rightly that we need to use every existing potential. Professor Fatima has rightly said that we need to use any resources that have, even research in low resource setting. For me, it is a very high motivation. And also about Turkish presentation, well, I am speechless, basically. You have a ready-made introduction model with all the limitations and benefits, how we should implement genomic technologies. Really, I'm impressed very much, not just going to fly to the outer space, but to be very practical and timely. As for Uzbekistan presentation, we have a very well-developed general system for medical care, for general medical care. And I respect Uzbekistani colleagues very much because they are starting really starting their journey for genomic diagnosis system. And they started with a special focus on registries of orphan diseases. This really gives a lot. And as for Belarus colleague, indeed, it is a reason for huge respect, because Belarus is a country that realistically evaluates their capabilities. They are not striving to do something which is fashionable or trendy at the moment, or very much breakthrough, but their positive side is a very stringent organization of neonatal screening, not just words, not just speaking about this, but a very specific, concrete monitoring for the prevalence of hereditary diseases. As for Russian Federation, well, I want to have it all in Kazakhstan, everything that you have in Russia. Well, if I was to select just one thing for introduction now, is the decentralization experience. Such a vast country, and there are, well, on top of federal levels, there are also interregional reference laboratories, which is indeed very important for reliability and precision of the genetic testing. Well, I believe that maybe I should give the floor to my co-moderator, to Professor Ayman, for a quick conclusion.
Oh, thank you very much. I mean, the I think we all agree about like the idea of exchanging experience and collaboration, and this platform is a unique opportunity for us now to keep the channels open and keep the discussion. This is just the beginning, and we hope by the end of this conference, as Dr. Nuria mentioned at the beginning, that will end with really conclusions and recommendations, and hopefully we'll end with the BRICS consortium that will help us to work more together, exchange knowledge, and move forward.
Once again, very big thank you to every participant. I wish you further success and see you next time, that's for sure. Thank you very much.